Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board certified nephrologist and clinical specialist in hypertension. Today's topic, the use of tolvaptan in hyponatremia. Tolvaptan is a vasopressin 2 receptor antagonist, also in the class of medications called an aquaretic. It results in water excretion from the kidneys without significant electrolyte loss. We're going to get into an overview of vasopressin, how tolvaptan works, indications for use, and when not to use this medication, as well as reasons for tolvaptan resistance. But before we get into that, make sure you check out the other videos at this channel. Check out bcnephro.com, where you'll find articles not only in this topic, but on a wide range of nephrology subjects. I'm also on Instagram at bcnephro. Links to all will be in the description below. But now, let's get into it. Vasopressin is also called antidiuretic hormone, ADH. They're the same thing. It's synthesized in the hypothalamus and then stored in the posterior pituitary. It is released when the body needs it. The main reason the body would need it is if you are dehydrated and need to preserve water. This is called osmotic stimuli for release. The second reason is hemodynamic. If someone has decreased intravascular volume, either true hypovolemia or an edematous state associated with a decreased effective arterial volume such as heart failure or cirrhosis, there is stimuli to release this hormone to help maintain plasma volume. ADH can also be released inappropriately, referred to as SIADH, the syndrome of inappropriate ADH. This is clinically seen in certain settings, including malignancies, CNS or pulmonary disease, and with the use of certain medications. Now, there are three vasopressin receptors in the body: V1A, V1B, and V2. The V1A receptors are mainly located on vascular smooth muscle cells and lead to vasoconstriction. This is the reason why vasopressin clinically is used as a pressor in the critical care setting. The V1B receptor helps regulate ACTH and corticosterone, but the receptor we're interested in the context of hyponatremia is the V2 receptor. The V2 receptor is located on cells in the cortical collecting tubule in the distal nephron. When the V2 receptor is activated, leads to an increase in cyclic AMP, and this in turn leads to insertion of aquaporin channels in the membrane. These aquaporin water channels allow for water reabsorption and result in a concentrated urine. This will tend to lower the serum sodium. Blocking this receptor with tolvaptan, which is a competitive inhibitor, will impair the insertion of aquaporin channels and therefore impair the reabsorption of water and result in water excretion with a dilute urine, tending to raise the serum sodium, and this is why it is used in hyponatremia. Tolvaptan is clinically indicated for the acute use of both euvolemic hyponatremia, such as in SADH, and hypervolemic hyponatremia, such as in congestive heart failure. In these situations, it tends to raise the serum sodium somewhere in between 3.5 and 7 over several days. There can be an overly rapid correction, which is typically defined as by more than 8 in the first 24 hours. The initial study showed a low incidence of this, less than 2%, but subsequent studies have showed this may occur in over 10% of patients and is something that is definitely clinically seen. Now, when not to use tolvaptan. The first context where tolvaptan should not be used is in hypovolemic hyponatremia. In this case, the water excretion induced by this medication, although it may help the serum sodium, can contribute to intravascular hypovolemia and make that worse. The second is an acute symptomatic hyponatremia. In hyponatremia with acute CNS symptoms, it's important to raise the sodium by approximately 5 milliequivalents per liter acutely to decrease the cellular swelling and get the patient out of risk of severe complications. Tolvaptan cannot do this predictably or typically quickly enough, and therefore, in this context, 3% saline is the preferred treatment. I would typically use 100 cc boluses of 3% saline until this desired effect of 5 milliequivalents per liter is achieved. The other thing to be aware of is tolvaptan is not FDA approved to be used in the context of liver disease. This is because in studies where tolvaptan was used to decrease cyst growth in autosomal dominant polycystic kidney disease, there was a significant incidence of abnormal LFTs. In that context, tolvaptan was used for a longer period of time and for higher doses, so this is somewhat debatable. Some would use tolvaptan acutely in patients with cirrhosis and ascites with hyponatremia. thinking that this is actually safer to use in that context than 3% saline. Because of this concern for LFT abnormalities, the FDA has also not approved this for prolonged use in hyponatremia that is greater than 30 days. Now I'm going to get into how I use this medication. I typically use it in hospitalized patients with at least moderate hyponatremia that is refractory to the more standard initial treatments of fluid restriction and medications such as urea and loop diuretics. Although osmotic demyelinating syndrome has only been rarely seen with the use of this medication, we still need to be mindful about overcorrection. So I typically check the serum sodium 6 hours after the initial dose, and I also suspend the fluid restriction for the first 12 to 24 hours to mitigate the possibility of overcorrection. Once it is confirmed that overcorrection has not occurred, then the fluid restriction can be reinstituted. I use additional precautions when this is used in heart failure. In heart failure, there's often a decrease in effective arterial volume, and there's often the use of loop diuretics. I typically suspend the loop diuretics for the first 12 to 24 hours after use of tolvaptan because I'm concerned about the use of both these medications concomitantly can affect renal function, resulting in a decrease in GFR. Once we confirm that renal function is stable, then I reinstitute the loop diuretics. I also typically do not use this medication chronically for hyponatremia. However, I have come across rare cases where I have needed to use it, specifically cases with SIDH in the context of small cell lung cancer that can be refractory to the conventional treatments of fluid restriction, urea, and loop diuretics. Now we're going to get into reasons for tolvaptan resistance. This can occur in about 15% of cases. There are several reasons for this. The first reason is very high vasopressin levels. Now in SIDH, the vasopressin levels are typically not very high. They may even be in the normal range, but they're inappropriately elevated for the clinical context of hyponatremia, where they should be suppressed. If the levels are super high, they may overwhelm the competitive inhibition of this medication. In this context, one can consider using higher doses to achieve the effect. The second can be seen in situations where there's a decrease in GFR or intravascular volume depletion, decreased effective arterial volume, such as heart failure. In this context, there may be increased water fluid reabsorption in the proximal part of the nephron, so there is less fluid getting to the site of action, the collecting tubule. If there is less fluid getting to the site of action, less water can be excreted. The third situation is if the patient drinks enough water to overcome the aquaretic effect. These conditions in this medication often is associated with an increase in thirst. When it is used acutely in the hospital, there is some control over fluid restriction, however. The fourth situation is there are cases where there are aquaporin channels despite low or indetectable vasopressin levels. This can be seen in a situation where there is an activating mutation in the vasopressin receptor. So that's it. Thanks for watching an overview of the use of tolvaptan in hyponatremia. If you made it this far, you might as well hit like and subscribe. Please share this video with someone who you think might be interested in learning about this subject and spreading the message word of mouth. That really helps the channel grow. Leave a comment or question below, and until next time.